Hello, you're welcome to this clinical case presentation on depression in Parkinson's disease. Enjoy, and we hope you have some lessons from this.
Thank you. Hi everyone, good afternoon. I'm Harry, I'm one of the GPSD1s, and I'm currently working with the older age community mental health team. I'm with Dr. Sharma, who's my clinical supervisor. This afternoon I'm going to be talking about a particular patient that I've seen whilst working with the team, who has an underlying diagnosis of Parkinson's disease and has also been suffering from symptoms of depression and anxiety. So our patient is 80 years old. He used to work as a business journalist for the Financial Times. He was diagnosed with Parkinson's disease back in 2019. And
interrupt, Harry, but your slides are not moving.
Oh. Can you guys see them now?
Yes.
Fine. I had this issue last time as well. Slideshow. So working now?
I can see our patient, the outpatient JC slide.
Yeah.
But also all the rest of the slides on your left on the tree, so it's not a proper slideshow.
Okay, fine. I think that's probably the best thing we can do right now. It's not working. Fine. Okay, but you can see the slide clearly, correct?
Yes.
Fine. Okay. Sorry, guys. I'll carry on. So he's an 80-year-old gentleman. He worked as a business journalist for the Financial Times, and he was diagnosed with Parkinson's disease in 2019. He was referred by the GP to our team last September, and he had no real past history of anxiety or depression. From a medical point of view, he was diagnosed with bladder cancer a few years ago and underwent a resection in 2017. His medications, he's currently on Sinemet to help with his Parkinson's disease. The mirtazapine is in red because he was on that till 6 weeks ago in view of his depression and anxiety. He was recently started on melatonin to help with his insomnia and is also on a PPI. So he was referred by the GP on 3rd of September in view of having these increasing suicidal, these negative and very morbid thoughts. He had initially presented to the GP because he was complaining of lower limb cramps and pains, and they were largely related to his underlying diagnosis of Parkinson's. During the consultation, I think the GP was able to pick up that he was also quite concerned over his mood, and elaborated that his mood was quite low and that he'd been having these quite negative, these morbid, these suicidal thoughts. He himself believed that the thoughts were triggered by the kind of remitting bouts of pain and discomfort that he was suffering from in relation to his Parkinson's. He also went on to describe that he was having very poor sleep and was very anxious over his underlying diagnosis. He had also been isolated from his family and believes that this kind of social isolation was making him kind of dwell on his thoughts further. In regards to that, he lost his wife in a car accident about 20 years ago, where he was the individual driving and was convicted for dangerous driving, was in prison for a number of years. So the family, since the passing of his wife, his daughter and his son haven't spoken to him since then. So that's been 20, 25 years now.
We need to make it very brief because we're from important meetings.
Yeah. So the initial assessment, which was done by our team on the 6th of October, from the consultation, we could clearly see that these suicidal ideations, these kind of morbid thoughts were very active, they were very present, and they were the real focus of his problems. They were largely related to his diagnosis of his Parkinson's disease, were largely focused around his kind of his ideas and kind of concerns over the disease itself. He had in no way taken any sort of steps towards harming himself or thinking about in what ways he would take his life. He also continued to have very poor sleep and quite bad dreams. He went on to state during that consultation that he wants to be kind of rid of his Parkinson's disease, and he realizes that the only way to do this was to end his life. His negative thoughts can be triggered by generally anything. They could be triggered by him watching television, him just sitting in his chair reading a book, or even when trying to fall asleep. And they're generally worse first thing in the morning. During that same consultation, he went on to kind of elaborate that going for a walk or talking to friends helps distract his mind and helps kind of prevents these thoughts from arising. He also kind of further stated that the social isolation from his family have made things more difficult for him. He stated that he wouldn't want to kind of kill himself in a malicious or messy way. If he was ever to do it, it would be something that was quick and effective. He also told us that he had joined Dignity in Dying, which is this kind of voluntary campaign where they're trying to campaign for the legalization of euthanasia. And he also told us that he was suffering from both auditory and visual hallucination, but has never acted upon them. So what he was kind of describing is that he would see maybe like a shadow of a figure in his conservatory. He would hear people having conversations in the garden, but he had never acted upon them and also understood at the time that they were not real. He has a very close friend who has nursed their partner through Parkinson's disease, and has seen every step that she took till the day she died. And he also worries about the cognitive and physical decline that he may have to also suffer through his disease progression. So from that initial assessment, the care plan that we kind of devised was that we would want to, in view of his depression, his anxiety, we wanted to start him on an antidepressant, and he was started on mirtazapine. We also encouraged him to kind of explore ideas around sleep hygiene and reduce his naps during the day to help with his insomnia. We wanted him to kind of continue activities that prevent him from focusing on these morbid thoughts. So, taking regular walks, talking and socializing with friends. And we also thought that maybe some form of psychotherapy would be helpful in his condition, and therefore had a psychology appointment booked for him. He was later followed up in January of this year, and there had been a general kind of significant improvement in his mood. He said that he wasn't having these morbid thoughts as much. They would occur in the morning, but generally reduce in frequency over the course of the day. He would have some positivity with the things he did within kind of routine daily activities. However, his insomnia continued to persist, despite even didn't show any improvement on being on lower doses of mirtazapine. His hallucinations did resolve, but he kept he continued to kind of research more about Dignity in Dying, and eventually also read about Dignitas, which is the Swiss organization which actually kind of performed the action of euthanasia. I actually saw this gentleman recently, a couple of weeks ago, on the 5th of April, and I just kind of jotted down a few of his active issues at the time. So from his initial presentation in September to April, it looks like the insomnia has been a persisting problem for him. I think it's generally been getting worse. He's only been able to sleep 2 to 3 hours at a time at night. He finds it very difficult to initiate sleep, and he now believes that this insomnia is not related to his Parkinson's, but believes it's quite focused and related to his mirtazapine. Therefore, has stopped taking the medication now for the past 6 weeks. Now, in view of this, his suicide or morbid thoughts, which had initially improved after starting mirtazapine, have now increased in frequency. He wakes up every morning with these thoughts. They can occasionally improve with the walking, but in view of his Parkinson's disease progression, his mobility is also worsened, so he's not being able to go on these walks as frequently and as regularly as before. He went on to kind of discuss that he actually has had thoughts about throwing himself under a train, but finds the idea, again, sickening or appalling. He did discuss about hanging himself, but again said that that would involve him struggling, and that if he really wanted to go, he wanted to go quickly and effectively. He seemed depressed. He couldn't see anything in a positive manner. He also said there was no real joy in his life. His anxiety, which was largely focused around his Parkinson's progression, has also worsened. He was very distressed about that. Working as a business journalist for a number of years, he also was very kind of aware that his ability to speak and was very important for his life, and the fact that his Parkinson's was making him difficult to articulate his words was something that made him very anxious, very worried, very depressed. He also started to feel very constrained and restricted within his home. He wasn't sure whether that was related to his mobility or there was other kind of psychosocial factors involved. He continued to have vivid dreams, and so vivid that he didn't want to fall asleep. He was so frightened that he didn't want to go to sleep. And I'm assuming that's probably contributing towards his insomnia. And then we finally come down to these adverse effects of his mirtazapine. He believes that a large number of these active or these present issues have been brought about by his mirtazapine. Therefore, has stopped taking this now for the past 5 to 6 weeks. So we discussed his case at our weekly MDT, along with Dr. Sharma, along with other psychologists and other members of our team. And we believe that in view of the worsening depression, in view of the fact that he's having these worsening morbid and suicidal thoughts, this increase in anxiety, we thought it would be suitable or appropriate to introduce another antidepressant. And what we did was we introduced venlafaxine at 75 milligrams. And what we would do would be reviewing him accordingly in view of the fact that we know that venlafaxine can also contribute to the worsening motor symptoms in someone with Parkinson's. We also wanted to rediscuss the options of him considering psychological therapy, because we know that CBT has quite an important role in people with depression and Parkinson's. I will be arranging a telephone appointment with him to discuss how he's doing on the venlafaxine, and obviously we safety netted him in view of his kind of suicidal ideations. So now,
I was just wondering if you had any questions they wanted to ask about the case as such. Any questions at all? Ari, can I just ask, in terms of his current medication, do we have an idea of whether he's being started on anything by his GP for insomnia at all? Was he on melatonin at some point?
Yeah, so he's been started on melatonin to help with the insomnia.
Yeah.
And that was recently started, I believe, I saw him on the 5th, so I think 2 weeks prior to that. So he's probably been on that for about 5-6 weeks now. And he believes that it's quite difficult because he's unsure whether this improvement in his sleep is related to the fact that he's now starting to take something to help with his sleep, such as melatonin, or whether it's because he stopped taking the mirtazapine. So he's quite aware of the different kind of effects that the drugs are having on his body, and I think the fact that he worked in a high profession, so he's quite able to articulate himself well.
Yeah.
But yeah, he's starting the melatonin. So I've discussed.
Maybe.
Yeah.
Sorry, I joined a little bit late.
No worries.
But when you went back to your earlier slides, he's only been diagnosed with Parkinson's in 2019.
Yeah.
That's just 3 years worth of Parkinson's. Has he been undiagnosed for several years before that?
I am not sure in regards to the history in keeping with what came about for him to be diagnosed with Parkinson's in the first place. But the symptoms that he's currently suffering from in regards to his Parkinson's are quite mild.
That was my next question. His anxiety around the whole Parkinson's and possibly his prognosis, is it proportionate to his actual motor symptoms?
No, it's not.
Right.
But the issue that he's had is that he understands that Parkinson's disease is a debilitating condition, and he knows that there isn't a cure for Parkinson's. What we're trying to do is just slow down the progression, and he's fully aware of that. And in view of that, he doesn't want to go through the whole process of suffering through every step until he comes to a stage where he's bedbound, or he's come to a stage where he's unable to speak, where he's unable to eat. He's fully aware of that, and he's thinking, why should I suffer through all these steps to get to that end stage when I can end my life now? That's what.
But I guess, but I guess again, just a thought. Have discussions been had with him where he's been diagnosed in his late 70s, so the likelihood is it's probably a vascular Parkinson's rather than idiopathic Parkinson's, and the vascular Parkinson's would run a very different course. And you sometimes see, or you often see this kind of debilitating effect of Parkinson's in people that have had Parkinson's for 20 or 30 odd years. And I guess, you can't paint everyone with the same brush. And have those kind of discussions been had with him? Because sometimes when people have a better understanding of, prognosis and
I'm not sure. I haven't been able to gather much information in regards to a neurological point of view. So I think what we've discussed going forward is that it'll be quite important for him to meet with his neurologist soon, so that he can kind of discuss, because we also understand that the mood disturbance, the anxiety could also be related to the kind of neuropsychiatric effects of Parkinson's as well. So definitely getting someone to talk to him about whether it could be vascular, or trying to encourage him, or trying to kind of elaborate more on the fact that the prognosis is quite different to the different types of Parkinson's would definitely help as well.
It's like saying cancer, and cancer again isn't black and white. If you've got bladder cancer or prostate cancer, that's very slow. It is a very different story to when you have pancreatic cancer, or and again, sometimes people, laymen will think in black and white terms. About that bit of medical education, I think that it could be a good piece of work. Definitely.
It's also very, very interesting, Mirat, that a lot of a good few of my Parkinson's patients do have this fear and this idea of doom and gloom, all about all or nothing, and apparently it's a lot more common in females. We did have a discussion about liaising with neurologists, and we're starting a clinic where we will see some of our patients jointly with Parkinson's specialist nurse. And I think some of these discussions can be had in that setup, where they can answer Parkinson's side of questions, we can answer mental health side of questions, and hopefully it will be beneficial for the patient.
That's good.
Well, I had a question. Nazar speaking. Has he had a data scan, or that was based on clinical observation, the diagnosis of Parkinson? And the second question, what about the cognitive profile and the hallucinations you mentioned? Were they illusionary type of like illusions mainly, or proper hallucination? Is it visual? And the description of visual hallucination is very important to differentiate if it was like Lewy body disease going on, or is the post-stroke depression, as Mirat said, probably related to vascular Parkinson. So the DAT scan here is important, and the details about the hallucinations. And how soon after you started antidepressant, the hallucination disappeared?
I didn't get the first part of your question, but for the second question, it appears So when we initially saw him, when he was referred, we saw him on the 6th of October. And that's when he was telling us that he had been suffering from mainly visual hallucinations, where he would see either a shadow of a figure or the outlines of a figure in his conservatory. So he would be looking from his downstairs bedroom through the living room into his conservatory. So that's about 15 meters with a panel of glass in the middle as well. So that was the main concern. So that had been happening probably for the past 6 months. Okay. So prior to October, the past 6 months, we started the medication around probably the middle of October, and we reassessed him probably the middle of January. So that's a period of 3 months. Okay. And based on the consultation, I wasn't exactly sure when the hallucination started to resolve, but now they have completely resolved. So difficult to say really. But and what was your first question? Sorry.
It's about the DAT scan. This is to identify the basal ganglia uptake of dopamine. So it's a nice guideline scan for helping in diagnosis of Parkinson's disease, but it has false negatives as well and false positives. But it's very useful investigation.
Zara, I think because the diagnosis was made back in 2019 by the neurologist, we're not entirely sure whether a DAT scan was done or not. A lot of times they do go by a clinical diagnosis. I wouldn't be surprised if it was a clinical rather than a radiological diagnosis.
Yeah, I had a few patients at the memory clinic with Lewy body dementia suspected and turned out to be we liaise with a neurologist, and we if the cognitive profile is fluctuating, we'll be having series of ACEs. If the cognitive profile is fluctuating, probably this may necessitate requesting that scan if it continues to fluctuate.
So from what I understand, I don't think there are any concerns with regards to his memory. We've obviously not done a formal cognitive testing, which we will be doing. And the plan is also to liaise with neurologists going forward in terms of managing this gentleman. But thank you.
Thank you.
Thanks. Are there any further questions about the case? And then I'm just going to quickly talk a bit about Parkinson's and depression.
Just one little question. Has ECT been considered at one point?
We haven't got that far yet.
He's only had one antidepressant so far, Nazar. He's only tried one antidepressant so far.
Yeah. He did have a psychology appointment earlier in March this year, but he, again, and we know that CBT plays quite a big or important role in people with depression and Parkinson's, but he refused. He didn't even want to speak to anyone. So we're thinking about taking another approach to see if he would reconsider, because that'd be quite helpful. But like what Dr. Moret said earlier, it might be quite important for us to also kind of identify what type of Parkinson's he may have, and to get a better idea of his prognosis, because that may also impact his decision going forward.
All right.
So just going on to a little bit about Parkinson's. So we all know it's a movement disorder characterized by these three things: tremor, rigidity, and bradykinesia. We know it is quite a debilitating condition, and the disease itself can trigger kind of feelings about your own symptoms, your physical limitations, and also the possibility of death. But what I came to also understand, that it's important to understand the neuropsychiatric effects of the condition, which can bring about depression, anxiety, sleep disturbances, and these are generally overlooked. Just kind of touching on the pathophysiology behind it, we know that there is a degeneration of the dopaminergic neurons and the intraneural Lewy bodies in the substantia nigra, which characterizes Parkinson's disease. But there's also this loss of noradrenergic and serotonergic neurons. And together, the disruption in these neuronal systems, how the kind of features and symptoms of depression and Parkinson's overlap, and because of this, it'll be quite difficult to differentiate if an individual with Parkinson's does have depression, or whether this is a kind of a psychological issue related to the underlying diagnosis of Parkinson's. So, like I said before, difficult to differentiate if the symptoms are caused by depression or they are the physical effects of the progression of the disease. Take, for example, Parkinson's disease can result in muscle weakness, and that can also be perceived as someone being depressed. For example, if they have downcast eyes, if they have this kind of flat expression, if they're not really showing any visible emotions, and a slow speech. Another thing that can cause both of them to overlap is apathy as well, which can also kind of present as depression, the loss of interest, the decreased energy, the appetite, and fatigue. And other things which can also overlap is this kind of low sexual function, difficulty sleeping, and memory loss. So the treatment of depression in Parkinson's disease, what I really wanted to highlight is that it's important to understand that Parkinson's disease is becoming more recognized as a complex disease with multiple neuropsychiatric complications, and depression being one of the most common. And this identifying and treating this will also bring kind of more of a positive impact on their quality of life. So our first line go-to would probably be medication, antidepressants such as SSRIs or SNRIs, or even tricyclic antidepressants can be used, but have to be careful that some of these medications can also worsen the motor symptoms of Parkinson's disease. Psychological therapy, more kind of commonly CBT, has been found to be quite effective in helping change people's negative thinking patterns and behaviors to reduce symptoms. ECT is an option that can be considered, and there's also the option of TMS, this transcranial magnetic stimulation, where not only does it help with the whole depressive kind of episode associated with Parkinson's, but can also help with the motor symptoms, the apathy, and the cognitive changes that kind of contribute with PD as well. Okay, guys, that's me done. Is there any more questions?
Hallucination actually rarely disappear after antidepressant treatment unless it's with psychotic depression. You spoke about auditory hallucination. What type of auditory hallucination?
He was telling us that he was hearing people have conversations in the garden. Okay. And when he went over to check who was there was no one present. But there was no kind of third-party person involved who was able to kind of confirm this. But he's a gentleman who from meeting him didn't seem to appear to have any form of cognitive decline or anything like that. So I can't imagine him to have made it up or anything like that.
Were any hallucination derogatory that may drive him to be suicidal?
Thank you for your email.
Can I please ask anyone who is not
Are they increasing the risk of suicide? Are they derogatory to them?
No, he didn't. He never went on to state that the hallucinations that he was suffering were contributing towards his kind of ideations of morbid thoughts.
All right. And how was his pre-morbid personality? You said that he lost his wife after a car accident 20 years ago. Did he have depression before? Parkinson.
He lost his wife a while ago, and when he lost his wife and he was sent to jail for a number of years, he also lost his son and his daughter because not in the sense that he physically lost them, but he lost contact with them. So I believe there must have been some form of kind of social isolation. There must have been some form of regret and possibly depression that he would have suffered before his official diagnosis. Yeah.
Any alcohol issues?
Not that we know of. He does drink, but no history of alcohol abuse.
Okay, thank you.
No worries, thank you. Any idea about the precaution?
I know that ECT is effective in improving symptoms of depression, but I can't tell you exactly what proportion of patients require ECT. Sorry, I can check and let you know later, Shweta.
From the general kind of research that I've done online, answering the second part of the question, I think it depends on the severity of the individual's underlying Parkinson's, but generally has quite a positive impact on their mental health.
Are most people treated adequately with antidepressants, do you think, with who have depression and ED?
I think there's a stigma that if in people with Parkinson's, if they do feel depressed, if they feel anxious about the condition, I think some of them just put it down to the fact that they have Parkinson's. I don't think they understand that this is probably another condition affecting them. I don't think they understand they possibly have got depression. And just trying to kind of educate them over that could be a problem is probably the first step we should take. But I think you're probably right in asking me that question, because a lot of people don't know. They just don't understand. They probably think it's part of their disease process.
Any past medical history, please?
For this individual, he was diagnosed with bladder cancer, I think, in the late 2000s, 2010 or something, 2011, something like that. And then he underwent a resection in 2017, for which he is still under remission. He has a urostomy in situ right now, which he kind of manages on his own. But apart from that, no other significant past medical history.
No hypertension, no AF, no hyperlipidemia.
No cardiovascular issues.
Okay. And his brain scan was normal?
I will not be able to answer that question. I wasn't sure what the scan showed, sorry.
Okay.
Any more questions at all?
I think there's chat. Oh no, it's just
Okay. If there are no more questions, thank you so much, Ari, for